Hello, my name is Kevin Matthews, and I'm an orthotist and owner of Advanced Orthopedic Designs in San Antonio, Texas. I did a video a couple years back on idiopathic toe walking where I discussed the brace design that I used to treat it. I didn't really go into idiopathic toe walking as a diagnosis much, and I have had literally hundreds of emails and phone calls and from people who are asking questions about toe walking. Is their child a candidate? Should their child be treated with this design? So I wanted to answer some of those questions here because there were many. Also, I just wanted to mention there's an article in Lower Extremity Review magazine that discusses idiopathic toe walking and how they feel, and I agree that it's a sensory issue, and they were trying to test for devices to try to be able to measure sensitivity for toe walkers. Anyway, that's just something you might look at if you just Google my name, Kevin Matthews, and toe walking, or Lower Extremity Review and toe walking. You'll find the article right away. So many questions that I get, and I would like to kind of clarify, are things like, is this something that we need to do for our child? What I would like to say is idiopathic toe walking isn't very well or studied very much. There is not a standard treatment protocol. There's not even a standard of care whether or not it should even be treated. Most doctors will tell you just he or she will grow out of it. Just, cue them, stretch them, make sure that you maintain their range of motion, and, hopefully they grow out of it. Some kids don't grow out of it, and it can become a problem later, which we'll discuss about possible complications. I'm not trying to scare anyone. I'm just saying this is what I've seen over my 32 years of bracing and managing toe walking. So, if your child is a toe walker and spends less than 50% of their time on their toes, I would definitely say let them go, cue them, remind them, but I don't think that it's something that needs to be treated. Some kids toe walk barefoot, but don't toe walk hardly at all when they're wearing shoes. Have them wear shoes, even in the house. Get them out of that pattern, because it probably is a sensory issue, and they don't like the feel of weight bearing through their heels, or they feel more comfortable with their weight forward on their toes. Shoes are kind of a desensitizing device. If the shoes make them toe walk less, have them wear their shoes. You would like to treat this with a minimal amount of intervention. If your child is the typical ballerina that I see, 90 to 100% of the time on their toes, the only time they tend to go down on their heels is when they're walking, and then they'll stop, then they'll drop down on their heels, do what they're going to do, and then pop back up on their toes and start walking again. Those are the more chronic idiopathic toe walkers, those that really consistently do that. And those are the ones that we want to consider treating. Now, in order to be a candidate for bracing, your child needs to have a few different things going on. First of all, they need to have adequate muscle range, and by that I mean that they have to be able to achieve better than 90 degrees, a little bit more than 90 degrees of range with the knee extended. So if the muscle has gotten tight and you're not able to, with their leg fully extended, raise their toes up past 90 degrees, then they may need to have serial casting or surgery, and some are even calling for Botox injections. And some are, I forget where, using Botox injection into the plantar flexors to treat toe walking. I'm not sure if that's been effective. There really isn't any information on that about that. What I do to test if kids are candidates, one simple test that doesn't require range of motion testing, is have the child walk on their heels. If they're able to walk, even if they can't balance, with their toes off the ground, they are a candidate. So if your child is a candidate and you want to go the bracing route, there are a couple ways to go. One is the design that I use, the SMO with plantarflexion stop. I like this design because it's a lot smaller, lower profile than a full-blown hinged AFO. Also, it doesn't force the child into that position. This obnoxious little bumper here catches the back of their calf and is uncomfortable if they try to walk on their toes. If they walk normally and achieve a normal heel straight, foot flat, toe off type gait, this doesn't bother them at all. It only bothers them when they try to get up on their toes. This is an incredibly effective design. It works every time on these kids that are candidates. They can still toe walk if they bend their knees, and they can walk on their toes, but that is very fatiguing and they won't do that for long. Prior to coming up with and using this design, I would use the hinged AFO with plantarflexion stop. It basically blocks the toes from going down and in effect keeps them off of their toes, forcing them into that position. This is an effective treatment. I don't use it anymore except on kids that are tight. But this design, if the child has any tone, any abnormal tone, they're not a candidate. With this design, yes, they can have tone. With this design, if they have tone, this bumper is going to cause bruising. They can't actively dorsiflex their foot typically with this abnormal tone, or even if they can, when they're walking, they can't really control it, and this will really dig in. With this one, the pressure's over a much larger area, very effective at managing toe walking due to tone. Again, this is for idiopathic toe walking, not for cerebral palsy or other issues where it involves abnormal muscle tone. Just trying to think of other questions that have been raised. And I think we'll go to the possible complications if the child is not managed. If you just let your child go and let them toe walk. Other countries in Europe, they don't treat toe walking unless it becomes a problem. They'll do a surgery to lengthen the Achilles tendon if they develop a contracture and just can't get their heels down. They'll do serial casting to stretch the foot out, but typically they don't brace. These things are expensive, $1,100, $1,200 a pair, up to $1,500, $1,600 depending on where you live. These are pricey. Both versions are about the same. I think this one costs a little more. But it's an expensive approach, but an effective approach. People ask, well, if they wear this, will they be cured? They won't necessarily be cured. What I recommend is a wearing protocol of 6 months, all day, every day, after the initial week or two break-in. They should wear them in the house, all waking hours. The child should use them full-time, not be allowed to go barefoot except when they're swimming, and basically retrain them that heel-toe type gait is normal, and this will hopefully get them there. Once, after 6 months, if this is discontinued, they may revert back to toe walking. There is no cure for toe walking, but we do get results. We have had patients that have had positive results. I just don't have studies, nor does anyone, as to which treatment is preferable or the best. So what I would say is it's worth a try, but you're not doing anything terrible if you don't treat the child. Maintain range of motion, stretch the child, and you will help prevent complications. I think as they get older and people start noticing more, kids start teasing, they will drop down and try to walk more normally. If they have a contracture, they won't be able to, which I've seen before. Kids that have been on their toes so long they no longer have the range, then they typically will go get surgery and then be in a brace just temporarily after surgery. And then if they want to walk normally, they can once they get the range of motion back. So it tends to resolve itself, but not in all situations. So the problems associated with toe walking over the long term. They tend to develop a very wide forefoot because the weight is always on the forefoot. The weight is designed to be carried over a larger area. If you're just on the ball of the foot, it tends to spread. They can develop hammer toes. They get very wide forefeet that are hard to fit in shoes. If they have good structural integrity of the arch, there tends to not be effects there, and a lot of toe walkers have good, strong muscles, intrinsic muscles that help maintain the arch. But if the heel turns out, if when they're on their toes and the tendon starts getting tighter and when their weight goes down, if the heel is turning out into valgus and the middle of the arch is collapsing, that really needs to be addressed. It can be addressed in this design. Once you get the foot out of alignment with a midfoot collapse in the heel in valgus, that tends to be progressive, and it aids in shortening of the Achilles tendon because the heel is off center. And when you bring the heel underneath the patient, they definitely have a contracture, and not only that, they have a valgus laxity. So they will need not only Achilles tendon lengthening, but possibly foot orthotics or SMO, a regular SMO or UCB, something to control that valgus. So that tight Achilles tendon can pull the foot off into a valgus alignment. And if you have a child with that heel more than just slightly turned out, you should see an orthopedist and have that looked at. So those are a couple of the possible complications, along with wearing out shoes a lot quicker in the forefoot of the shoe. Like I said, other countries don't necessarily treat it. You can wait and see if your child grows out of it. Typically by 7 or 8, there's going to be a contracture present. So if you wait that long, then you'll probably need some other intervention, like a tendon lengthening Botox or a serial casting, just to be able to try to use one of these braces to treat it. A lot of times they'll just do surgery, lengthen the Achilles tendon, be in the cast for a while, and see how the child does after that. Once they're 8 or 9, 7, 8 or 9, they may want to heel walk. The Achilles tendon lengthening surgery gives them that capability. I don't know what the long-term effects are for the scar tissue that develops after surgery, but I haven't seen anything that shows that it's very detrimental long-term. So I hopefully have answered a lot of questions you may have with toe walking. I know it's kind of a long video, but I just get a lot of questions about whether or not the child is a candidate, whether it has to be treated, when to start treating it. I've started treating it as young as 2.5 years old based on physical therapist recommendation and the parents wanting to nip it in the bud and catch it early. I typically don't recommend that. I think typically by 4 or 5 is a good time to see if they will outgrow it. Again, these are expensive. Hopefully they do outgrow it. Once after 4 or 5, they start developing tightness or contracture, and then it becomes more difficult to treat. So just some things to consider if you're considering bracing for your child that has tiptoe walking or idiopathic toe walking. Thanks. Hopefully I've answered some questions you may have had.